Today I want to talk with you about atrial fibrillation. Let me start with a question that you're probably asking, and that is, what is atrial fibrillation? Atrial fibrillation is a condition in which the atrium quivers without truly contracting. This is due to the fact that multiple areas in the atrium are acting like the SA node. These ectopic stimuli cause the atrium to quiver but not contract. Let's classify atrial fibrillation. It may be classified as paroxysmal, that is, it is self-terminating, or intermittent. Paroxysmal AFib is defined as AFib that terminates spontaneously or with intervention within 7 days of onset. The next classification is persistent AFib. Persistent AFib is defined as AFib that fails to self-terminate within 7 days. Episodes often require pharmacologic or electrical cardioversion to restore sinus rhythm. The third classification is long-standing persistent AFib. Long-standing persistent AFib refers to AFib that has lasted more than 12 months. And the last classification is permanent AFib. Permanent AFib is a term used to identify persistent AFib for which a joint decision by the patient and clinician has been made to no longer pursue a rhythm control strategy. It is important to know that atrial fibrillation is the most common supraventricular tachyarrhythmia. Atrial fibrillation may be identified by the following. Number 1, there are no P waves. Number 2, there is an irregular rhythm. Number 3, the ventricular rate may be slow, normal, or rapid. And number 4, AFib may be acute or chronic. This is what it looks like. We have two strips. One is a normal EKG showing the SA node is firing appropriately. The other is atrial fibrillation, which shows multiple indications of ectopic stimuli from the SA node and the atrium itself, resulting in quivering as there is no identifiable P wave on the strip. Let's talk about the clinical presentation of atrial fibrillation. Patients may present with palpitation or tachycardia or complaint of fatigue, weakness, dizziness, lightheadedness, and the sense of passing out, which is pre-syncope. They may complain of reduced exercise capacity or increased urination or dyspnea at rest or with activities, and they may complain of angina. The complications of AFib. The most dreaded complication of AFib is an embolus either to the brain, resulting in a stroke, or to the mesenteric vessels, resulting in mesenteric ischemia. There are also mental changes, myocardial infarction, and death. The treatment. The two most important components of treatment are rate control and rhythm control. Keep in mind that it is the ventricular rate that is being controlled. Once the rate is controlled, the symptoms will improve and the rhythm can then be converted to normal sinus rhythm. An atrioventricular nodal blocker, such as a beta blocker or a rate-slowing calcium channel blocker, is usually started before or simultaneously with antiarrhythmic drug therapy in patients who have demonstrated a moderate to rapid ventricular rate, and that is a rate greater than 110 beats per minute during Afib. Slowing of the rate generally improves the symptoms prior to the restoration of sinus rhythm. What about a person with chronic Afib? A patient with long-standing persistent Afib may be scheduled to have electrical cardioversion as an outpatient. In such a case, the patient would be anticoagulated 3 weeks before and 4 weeks after the procedure. Finally, patients with Afib should be on an anticoagulant, preferably Coumadin for life. Patients should be reminded that if they are on Coumadin, they should avoid eating green leaf vegetables. Well, thanks for watching. Please don't forget to like, share, and subscribe. I wish you well. Good night.